Well, good evening. It's my task to bring this day to a close. I'm going to talk about these complications that we may encounter during our stints in the ICU. So sorry for this long list. I hope it won't be too boring, but to set the scene, first of all, I wanted to say that these are pathologies that are a lot more frequent in centers that have hematology and oncology departments, but any one of us may encounter them also in their own centers for the most part. These are frequent pathologies in expert centers like those of the GRRR, and these studies highlighted that about every fourth patient of hematology who went into the ICU would receive chemotherapy in the ICU, with survival rates higher than 60% at discharge of the hospital. So clearly it's worth it, and these results were also published by our Austrian colleagues, who also reported survival rates that are quite interesting in hematological patients receiving chemotherapy in the ICU, with survival rates close to 40% at 12 and 24 months. These are patients who are going to justify aggressive treatment to support failing organs in association with specific treatment of malignant blood disorders. But it's also very important to kick off this presentation to say that it's clearly something that's worthwhile, because this will induce survival in a number of patients and long-term survival at that. The first complication I wanted to talk about is probably the most frequent, the one that you'll encounter most often: tumor lysis syndrome, with a distinction between biological lysis syndrome, with the anomalies highlighted in red, those that are probably the most frequent and the most relevant, which are generally due to the release of substances that are normally contained in the cell and that shouldn't end up outside the cell. And at the bottom, what we've called clinical lysis syndrome, with renal manifestations that are clearly at the forefront, and also cardiac arrhythmia and seizures that I have personally rarely or even never seen, that may be linked to hypocalcemia. Someone's worked a lot on that, and I hope that I won't betray his thought. Michael Darmon. And Michael highlighted that the development of acute kidney failure in a tumor lysis syndrome was a negative predictor, and preserving renal function should be considered as a therapeutic objective, major therapeutic objective for us in this situation. These are the traditional manifestations of lysis syndrome, and this is something that we know in the ICU. They are patients who come with a sepsis-like situation without infection. That may be the case in lysis syndrome and also for other specific complications that I'll talk about. With patients coming with an SRLF situation, organ failure that may be evocative of sepsis, but they have specific origins. There are case reports that were published in the literature, and this one in particular that I'm fond of, the case of a patient who had high-grade lymphoma, and that was induced, and during induction he had a deterioration in his ventilation, deterioration in kidney function requiring hemofiltration, and the release of these various substances which are normally contained in the cell. And there was also another measurement of cytokines that were released in the lysis syndrome, with a production of pro-inflammatory cytokines, IL-6, IL-10 or TNF. The scale on the left is logarithmic, and you can see major increases which are usually found in endotoxemic shocks. And I think that this case really illustrates well this possibility of major inflammatory response induced by tumor lysis. The risk factors of tumor lysis syndrome are well known. I'll insist on type of tumor because these are mostly hematological diseases which are high grade, but they can also affect solid tumors, rapidly renewing bulky tumors. The prototype here is small cell bronchial cancer. It also depends on the tumor mass. So bulky tumors with large tumor masses or acute leukemia, which are hyperleukocytic. And there can also be Lysis syndrome that is spontaneous, where there's ultra-fast renewal of cells with angiogenesis in the tumor not keeping up with cell necrosis that will induce spontaneous Lysis syndrome, but more frequently Lysis syndrome will be induced by cytostatic treatment. So it's important for our colleagues in hematology and for ourselves to know how to take into account Lysis syndrome. And so our colleague Michael highlighted risk factors for the onset of Lysis syndromes in patients with malignant blood diseases. So this is this code developed by Michael, which is interesting, based on very simple factors, LDH, phosphates, and DIC. You could define Lysis syndrome, especially the risk of severe Lysis syndrome, with the need to manage that through extra renal replacement therapy. Preventive and curative treatment of Lysis syndrome overlap. They're very similar, based on hyperhydration in order to have a urinary output that's fairly high, avoiding to provide potassium because they may release a lot. Same thing for phosphorus, and no calcium input, even in the case of hypocalcemia, because if you provide calcium, that will mechanically increase the fulvocalcic product, with the risk of intratisular precipitation, especially in the kidney, which may be precipitated by alkalinization, which used to be recommended to avoid having crystals of uric acid, but now with hyperuricemic agents that we have, it's not justified, and alkalinization may promote the precipitation of phosphocalcic products. So hyperuricemic agents that we have are very effective. Rasburicase is very effective but a bit expensive, and also allopurinol, which is better suited to chronic situations, but which can also be used in rare cases of contraindication of rasburicase. We use early renal replacement therapy. You shouldn't wait to be overwhelmed by iron disorders, and there's also progressive chemotherapy. In concert with our hematological colleagues, will have chemotherapy to control the disease, to have minimal lysis in order to avoid massive lysis that may be induced by full dose chemotherapy. That's very traditionally what we do in lymphoma with corticosteroids alone or associated with vancomycin or prednisone in COP protocols. Hyperleukocytic ALL corticosteroid, hyperleukocytic AML, we use hydroxyurea, more or less, associated with purinethol. Another thing I wanted to discuss, pulmonary involvement in acute leukemia, especially monocytic leukemia, AML 4 and 5. Monoblastic is 5. Very often they have pulmonary manifestations, like this patient that we had who came to the ER with diffuse pulmonary infiltrates with acute monoblastic leukemia type 5, with physiopathology that was not univocal. And so there were 3 different mechanisms. So thank you to Anne-Sophie Moreau for giving me this slide, which really illustrates these 3 different mechanisms. First of all, you've got leukostasis, especially when there's a major hyperleukocytosis here, with obstruction of lung capillaries. Second mechanism is pulmonary infiltrates with the presence of leukemic cells in the lung interstitium and sometimes in pulmonary alveolus. If you had bronchoalveolar lavage, which we don't do, you may recover blastic cells, and in these patients it's not necessary to have major hyperleukocytosis to have this type of manifestation. And there's also Lysis lung disease that is induced after chemotherapy is started. It is a direct consequence of intrapulmonary tumor lysis with intraalveolar bleeding and diffuse alveolar harm. For these entities, there are various therapeutic courses that may be proposed in association with traditional chemotherapy of acute leukemia. For instance, for leukostasis, what was proposed is to reduce circulating leukocytes with leukapheresis, which is still done by teams, especially in the US, and also a few French teams, but overall it's no longer done by most teams because you waste time, and also because these are rapidly renewing cells, so they go back up immediately, and so you follow a strategy to reduce that with a high-dose hydroxyurea. Another therapeutic course that may be proposed is steroids, which may have multiple modes of action in this pathology, and the efficacy of corticoid therapy was proposed by this study by Elie Azoulay at Saint Louis Hospital. He suggested in this work that corticosteroid therapy, dexamethasone 10 milligrams times 2 times a day, would limit the deterioration, respiratory deterioration, the use of invasive ventilation support, and reducing ICU mortality. This was a historical control case with cohorts that were over 10 years apart, with more progress in intensive care that was achieved in the meantime. But corticosteroid therapy was not harmful, and it may even suggest that it may be relevant in this indication. Another disease I wanted to tell you about, AML3, promyelocytic leukemia. It's fascinating. Historically, it was considered as the worst acute leukemia because it was the one that killed quickly, especially because of complications of the acute phase that I'll tell you about. But now, maybe it's probably the type of acute leukemia that has the best prognosis, with full remission rates and curing rates that are above 90%. To be maybe a bit simplistic, but all patients who are not going to die at induction will be cured of the disease. Still, in this work, there are 9% of patients will die on induction, and they'll die either of hemorrhagic complications or of other types of delayed complications, differentiation syndrome, and also some patients who will die of infectious complications because of aplasia. First, coagulopathy. This is a very characteristic manifestation of promyelocytic leukemia. It's a constant in this pathology. The situation of coagulopathy is very complex because it associates, on the one hand, thrombophilia, and on the other hand, fibrinolysis, major fibrinolysis, that may be oversimplified on this slide here, with thrombophilia that's linked to the release by malignant cells of tissue factor, and also of a molecule called cancer procoagulant that directly stimulates factor 10. And on the other hand, you've got major fibrinolytic activity linked to the production by malignant cells of annexin A2 that is going to activate the plasminogen activator, and so induce the creation of plasmin, and so fibrinolysis and fibrinogenolysis. These two biological situations coexist, but quite clearly hemorrhagic complications take pride of place here, and In a few cases, there are thrombotic complications, but very clearly the danger here and the risk for our patients are hemorrhagic complications. And this is what will need to be taken into account. These hemorrhagic complications are directly influenced by a low level of fibrinogen when the fibrinogen level is less than 1 gram, and by a white blood cell count that's high. And for AML3, it's not for like the other types of leukemia, it's 10,000 or 20,000. And the therapies that we'll use will be aiming to maintain hemostasis that's sufficient, fibrinogen over 1 gram and platelets over 30 or 50 giga per liter. Anticoagulant treatment are counterindicated for the reasons that I explained, and patients will be treated for hyperleukocytosis. First of all, they'll be treated with what revolutionized the retinoic trans 2 acid, ATRA, and also patients are hyperleukocytotic, leukocytotic, and here plasmapheresis is counterindicated because it was associated in some cases with the activation of fibrinolysis and severe hemorrhagic complications. Here, these are complications at the onset of the disease, and over the course of the treatment, there may be what was called the ATRA syndrome. It's now called differentiation syndrome because it may also be related to another treatment of AML3, which is arsenic, because of the differentiation of the promyelocytes with the activation of promyelocytes. And here the symptoms on the left are not specific at all, and they could be found in quite a few inflammatory situations. As for coagulopathy and hemorrhagic complications, the risks of differentiation syndromes are associated with hyperleukocytosis. And what was seen is that the risk of severe ATRA syndrome was increased independently when the white blood count was over 10,000. And regarding the physiopathology of this pathology, a Dutch team proposed a model based on experimental work that was very interesting and published in Blood in 2009, with ATRA inducing the differentiation of leukemic cells, the production of chemokines, and also the production of chemokine by epithelial cells coming from normal lungs. And so the treatment of ATRA syndrome is corticosteroids, especially in dexamethasone, which is very interesting because dexamethasone only seems to modulate the production of chemokines at the level of the lung, and so inhibits the recruitment of leukemic cells at the level of the lung. For differentiation syndrome, there are also guidelines for treatment based on steroid therapy, and stopping differentiating drugs like ATRA or arsenic is only recommended in case of failure or severe cases of differentiation syndrome. And then lymphoma activation, macrophage activation syndrome, hemophagocytic lymphohistiocytosis. Here you have fever, cytopenia, high ferritin levels, LDH increased, and hemophagocytosis. That's not necessary for diagnosis. These patients may come to the ICU with various organ failures. And coming to therapies, here a quick drawing. It's not a macrophage disease, it's lymphocyte. disease that's hereditary, and because of lack of cytotoxicity, CD8s or NK lymphocytes are not able to induce cell death, but they'll stay hyperactivated and hyperproductors of one cytokine that's going, two cytokines that will activate macrophages. And there are also macrophage activation syndromes that are acquired related to lymphomas or infections and systemic diseases. The cytotoxic cell that's activated will produce a lot of interferon gamma, which is the main activator of macrophages, and macrophages will be hyperactivated. That will lead to hemophagocytosis, leading to pancytopenia, and they will release pro-inflammatory cytokines with manifestations like fever, activation of coagulation or organ failures, and they'll also induce the production of interleukin-12 that will maintain the hyperactivation of the lymphocyte with a sort of vicious circle. The therapies available for lymphoma will target the disease, corticosteroids or chemotherapy, but we also have therapies that may silence the disease, and here in this case VP16 is a topoisomerase II inhibitor. For a long time we thought that it was mostly active for the activation of macrophages because it's a cytotoxic drug that's maybe not selective, but that mostly affects monoblasts. But 2 years ago, they used animal models to model macrophage activation syndrome. They were perforin deficient animals. That's a molecule that's important for cytotoxicity. They were infected by choriomeningitis, lymphocyte choriomeningitis, and here you can see that the mice in black that had no perforin died quickly, and they produced a lot of interferon gamma with rescue through etoposide treatment to induce survival of all of the mice. And I'll gloss over what's in the rest of this paper, but etoposide do not really target macrophages. They target the activation of the lymphocytes, so VP16 mostly acts through this pathway, and also they target lymphoma cells. So you need to be aware that malignant diseases, especially blood diseases, may be directly responsible for organ failures. It's very important to recognize them, to put diagnostic procedures in place, and to induce a specific treatment. This will require close cooperation with our hematology colleagues in order to decide the best timing and the best type of treatment induced to avoid worsening the conditions. Thank you so much.
Merci beaucoup, Frédéric.
Thank you so much, Frederick. Are there any questions from the floor? Thank you for this excellent presentation. I have a question regarding the macrophage activation syndrome after lymphoma. If we receive a patient with severe MODS in the ICU with a lymphoma under treatment, this may justify to add etoposide, if that was not part of the chemotherapy, to treat the symptoms of macrophage activation syndrome if we feel that the patient will not make it through reassessment after the end of chemotherapy? Yes, in my experience, it's rather the other way. Patients will come with macrophage activation syndrome. It may be exacerbated with chemotherapy. There may also be some Lysis syndrome with SIRS related to the Lysis. So we'll take the patients the other way around, trying to silence the symptoms of macrophage activation syndrome through VP16 with 1 or 2 shots. And be careful, it's not trivial for patients, especially with kidney failure. So we'll try to silence that before we introduce specific chemotherapy for lymphoma. And then there are protocols for patients who have no severe macrophage activation syndrome. Either we can have specific chemotherapy for the lymphoma like CHOP, or chemotherapy that includes VP16 on top of the traditional chemo. And if we consider that in this case the main trigger of the MES is lymphoma, first we need to have etopocytes to control that. Well, after I've been scolded by a number of sudden exacerbations of organ failure when inducing chemotherapy, even fairly mild chemotherapy, COP for instance, without anthracycline, well, for some patients who were considered at risk, but it's very empirical, we had a sequence with first VP16, and VP16 is very spectacularly efficacious, if not on organ failure, but at least on manifestation symptoms like fever. You get rid of that in 1 to 2 days, and once it's stabilized, you can go for more traditional chemotherapies. But that's really a specialist discussion that we need to have with hematologists. Other questions from the floor? Well, in the meantime, just talking about DDX. The whole session was being able to manage specific failures. Lysis syndrome has symptoms that's very close to uremic syndrome. How do you tell them apart? How do you tell acute renal failure from early Lysis syndrome and macrophage activation syndrome? Well, good evening. It's my task to bring this day to a close. I'm going to talk about these complications that we may encounter during our stints in the ICU. So sorry for this long list. I hope it won't be too boring, but to set the scene, first of all, I wanted to say that these are pathologies that are a lot more frequent in centers that have hematology and oncology departments, but any one of us may encounter them also in their own centers for the most part. These are frequent pathologies in expert centers like those of the GRRR. And these studies highlighted that about every fourth patient of hematology who went into the ICU would receive chemotherapy in the ICU, with survival rates higher than 60% at discharge of the hospital. So clearly it's worth it, and these results were also published by our Austrian colleagues, who also reported survival rates that are quite interesting in hematological patients receiving chemotherapy in the ICU, with survival rates close to 40% at 12 and 24 months. These are patients who are going to justify aggressive treatment to support failing organs in association with specific treatment of malignant blood disorders. But it's also very important to kick off this presentation to say that it's clearly something that's worthwhile, because this will induce survival in a number of patients, and long-term survival at that. The first complication I wanted to talk about is probably the most frequent, the one that you'll encounter most often, tumor lysis syndrome, with a distinction between biological Lysis syndrome, with the anomalies highlighted in red, those that are probably the most frequent and the most relevant, which are generally due to the release of substances that are normally contained in the cell and that shouldn't end up outside the cell. And at the bottom, what we've called clinical Lysis syndrome, with renal manifestations that are clearly at the forefront, and also cardiac arrhythmia